We spend our whole lives looking at the world, taking it all in through our eyes. But how often do we stop and think about how every single piece of that system, the cornea, the lens, the retina, the optic nerve, has to work in perfect harmony for us to see anything at all? What happens when just one tiny piece of that chain breaks down? I sat down with Dr. Jonathan Carrere, an ophthalmologist down in Thibodeau, and this guy's story is something else. He's from Dulac, grew up down the bayou, and he originally thought he was going to be a soccer superstar playing for Arsenal. He wasn't. He was not. But life had other plans, and now he's changing people's lives in 10 minutes or less with cataract surgery. We got into what it's really like working on one of the smallest, most intricate structures in the human body. He talks about how there are 10 different fellowships that I had never even considered for ophthalmology, all within glaucoma, retina, ocular oncology, ocular plastics, because the eye is just that complex. And the wild part, he chose ophthalmology because he wanted to be home every night with his family. It's one of the few surgical specialties where you can actually have that genuine work-life balance. Jonathan shares what it's like to give sight back to people who've been completely blind from cataracts, including a woman in Guatemala who couldn't see or hear, and he gave her vision back in one eye. He talks about the misconceptions people have, like thinking he takes the eyeballs out to do the surgery. He does not. He explains why reading glasses don't actually hurt your eyes, and what minimally invasive glaucoma surgery is doing to prevent people from going blind. But what really stuck out to me about this conversation, 90% of the time, the answer is right in front of him. He just has to look. No MRIs, no CT scans. Just looking at an eye and knowing exactly what's wrong. I think that's something genuinely unique in medicine. And it's also not lost on me how every single part of the visual system has to work perfectly for us to see. If your cornea has a scar, you don't see. If you have cataracts, you don't see. If your optic nerve is damaged, you can't see. It all has to work together. Oh, and he's also a private pilot now, working on his instrument rating, because apparently being an eye surgeon wasn't technical enough. If any of this resonates, if you've ever taken your vision for granted, which I hope no one does, if you're curious about what actually happens during eye surgery, or if you just want to hear about someone who turned down soccer stardom to change lives for one surgery at a time, you're going to want to hear this one. You can catch the full episode on YouTube or pull it up wherever you listen to your podcast. Just search The Last Zebra. All right, let's get into it.
You change someone's life in a 10-minute or less surgery. There's really few better feelings in the world, man. What ophthalmology offered was a pretty good lifestyle that I can enjoy my clinical work, but also be at home every night with my kids, Describing all of the things, all of this new technology that's out there between the different types of lens implants and different types of surgeries we have nowadays. That's really where the art comes in.
Welcome back to another episode of the Last Zebra podcast. I'm your host, Ugo Ezama, and as always, please don't forget to like, share, subscribe. We've been trying to get Dr. Jonathan Carrere on the show for the better part of 10 years.
10 years? It's been 1 year.
We tried to get him on the show.
Happy to be here, man.
Thank you. Welcome to the podcast, man. Thanks for taking the time.
Yeah, of course. Thanks for the invite, man.
Of course.
Yeah.
So you are an ophthalmologist.
I am an ophthalmologist.
Am I saying that right? Off or op?
Ophthalmologist.
Why the H?
It's a P.
There's no age?
It's silent. You know,
Okay.
It's silent age.
Okay. I think I've been saying ophthalmologist my entire life. For our casual viewers and listeners, what is an ophthalmologist?
Yeah, so an ophthalmologist is a medical doctor, an MD, that does surgery on the eyeball and treats medical diseases of the eyeball. So things like cataract surgery, LASIK, eyelid procedures, all of those things, laser procedures for the eye is most of what I do. Yep.
And you are from here, Louisiana.
Yeah, so I'm from South Louisiana. I'm from Dulac, of all places, Dulac, Louisiana. Grew up
That's down
around
the bayou.
that, and that's down the bayou. Grew up in the Houma area. Went to high school in Houma, and then after that, traveled up to Shreveport, Louisiana, the Great North, and went to Centenary College up there and stayed
For
up,
college?
For college, yeah, Centenary.
I never heard of that.
Yeah, it's a small liberal arts college.
The Nichols of Shreveport?
It's smaller.
Smaller than Nichols?
Smaller than Nichols.
Nichols State is my alma mater.
Yeah.
Harvard on the Bayou. I don't think we can say that anymore.
You're right. No, I loved it up there, at least the school. And I stayed up in Shreveport for med school at LSU up there. So.
Oh, wow. Yeah. Did you always know you wanted to be a physician, a doctor?
No. I was going to be a soccer star, man. I was, So growing up, high school, I guess starting around 8, 9, I got really into soccer. Was training daily, and I thought I was going to be a soccer superstar for the best soccer team in the world, Arsenal.
Oh my goodness. I just knew there was a chance that you'd show up here with your Arsenal apparel, and here you are, of course.
Yeah, I've seen a couple of the podcasts before, and I've seen some Liverpool gear in the footage.
This is a professional podcast, you know?
Very much so. Yep.
How did you become an Arsenal fan?
So that was, I guess, the late 90s, 98, 99, when I really started getting big into soccer. And, man, that's when Thierry Henry started coming on the scene. He's my boy.
He's electric.
I love Thierry. He's
arguably the best Premier League player ever.
Oh, yeah. Arguably. Definitely.
I can't think of many other Premier League players that really just stood out. Won everything.
Yeah.
Was a class player. I remember as a Liverpool fan just being terrified whenever we played.
Yeah.
World class quality.
Part of the Invincibles, man. He was amazing. Yeah.
Well, so you wanted to be a soccer player.
Yeah.
Mm-hmm. And when did your dreams shatter to be a ophthalmologist?
I guess whenever you're that young, you feel like you can do really anything. But getting into high school, just learning more about what it takes to actually become top league in the Premier League.
Oh, you really thought about it?
Man, I was going for it. What it takes to get to that level was just, I was already 10 years late, so that's whenever the dream just shattered for me, and had to find an alternative, unfortunately, but here I am where I need to be.
Landing on medicine isn't too bad of a gig.
Not too bad, man. I guess in high school, toward the end of high school, we had to go talk to a community helper, I guess, a person in the community, community professional about their job and kind of what they like about it, and just thinking about what were the possibilities. I kind of leaned into the sciences, so kind of naturally thought about the physician. and went and talked to an orthopedic surgeon. He still operates in Houma
Today?
Dr. Casey.
Oh, yeah.
Talked to him several years ago whenever I was in high school. And that kind of started the push.
That's Brent Casey, right?
Yeah.
Yeah. Orthopedic legend down in Bayou, down the Bayou.
Yeah.
In Houma.
For sure. So
how then, because ophthalmology is not your classic medical field by any stretch of imagination. You guys have a different pathway almost for everything.
Right.
What was your exposure in the beginning for you to say this is the way I want it to go?
Yeah, definitely ophthalmology wasn't even on my radar as a thing that could be a possibility. First thought about ortho, and then as I got into the sciences a little bit more in college, doing kind of some higher level like cancer biology, biochemistry, that sort of stuff, I thought, well, oncology seems pretty cool because of the biology behind it. And clinically, when I got to med school, that side of oncology was tough. So like I enjoyed the scientific parts of it and how these newer drugs are working on specific cancers, but from a like straight up taking care of the patient and being a human being, that was the hard part for me when it came to oncology. So I kind of stepped back, went to all right, I thought surgery was cool back in high school. Let me start looking at that a little bit more. And on the third year rotations, I think ophthalmology was an elective, so I signed up for that, and within the first case, I knew that that's what I wanted to do.
Whoa! Was there anything in particular about that case that drew you to the eye?
Yeah,
that caught your eye.
It was just a see what you did there. It's really funny.
You see what I did there?
Yeah, that was good. No, I mean ophthalmology just in general. We work really hard when we're in clinic. We work really hard when we're in the OR.
Right.
But we're not working crazy hours. And at that point, I was already married. Got married first year of med school.
Shout out to
Jade
Carrere.
Yeah.
Future guest of the podcast.
Future guest for sure. And knew that we wanted to build a family. That was kind of number one priority for us when we got married, and wanted to be flexible from a life standpoint and be available for family. And what ophthalmology offered was a pretty good lifestyle that I can enjoy my clinical work, but also be at home every night with my kids,
It's not something I think about for surgical specialties, especially ophthalmology. That's a very technical field. I don't know why in my mind I always thought of, even as a physician myself, almost all surgical or surgically oriented specialties as not having that work-life balance.
Yeah.
And I can't think of many others. And this is my first time learning that ophthalmology, maybe I should have been an ophthalmologist, but that ophthalmology has that available or, available to you as a provider.
Yeah. I think that's a big draw to being an ophthalmologist, really. At least for me, it was. I knew I wanted that family life. It's called to be a father. So I wanted to be there for my kids, be there for my family, and that was a big pull for me. A lot of ophthalmologists, not all of them, but many ophthalmologists are in private practice, and it allows you to kind of create your own schedule. So my private practice, I make my own schedule. I can take a day off if I need to. I can take a half day off if I need to. And be there for my family. So.
What's the typical route? Obviously, you go through 4 years of medical school, an intern year, I'm sure.
Yeah.
And then what, 4 years? Another 4 years of ophthalmology residency?
So 4 years of med school, and then intern year, which is depending on how you do it and where you do it. It could be included in your residency or not. The one that I did up in Jackson, UMC in Jackson, Mississippi, fantastic program. Really, really prepared me. It was challenging, but saw a lot of terrible pathology that got me ready
and that's
for
important.
practice. So, especially down here, which, the population is pretty much the same as up there. But in terms of, I'm sorry, what was your question?
Right. I was asking, like, if for ophthalmology specifically, what is the pathway? So you do, and how many years?
Yeah.
How many years?
So it's 4 years of med school, and then intern year. Intern year for me in Jackson, we did a couple months of ophthalmology, but the rest were all internal medicine. So you're thrown in there with all the internal medicine residents doing actual doctor stuff and taking care of really sick people. And then the last 3 years are just straight up ophthalmology and surgical training.
So it's 4 years total.
4 years total.
I see. And you do have a separate match.
Match from the general match.
From the general match. Yeah. One that you find out earlier than the general match even.
Yeah, if I remember right, it's SF match. And I think you find out like in February.
Right.
I think you find out like a whole month or so before everybody else where you're going to go and all of that. Why they do that, I don't know. But
the eye is, going through medical school, the eye and learn about anatomy and all of the things that make up the human eye, it is so complex. And I think even if I was to entertain the idea of being an ophthalmologist from medical school, that you could mess up somebody's eye and understanding the intricacies and the detail that is one of my proofs for grand design is the eye. It's just so much going on in there, and that would have scared me into doing any sort of procedural or operating anything with the eye.
Yeah.
How did you consider that, and how did you overcome that?
No, it's a good point. The eye, just with this one of the smallest organs in the human body, smallest structures in the human body, and then individual structures even within there, and how they function it's a beautiful, amazing thing. I think just stepping back from it all, if you look at the individual fellowships within ophthalmology, it really tells you like how detailed all of this stuff can really be. I think even within ophthalmology, there's maybe like 10 fellowships.
What?
Yeah. So there's like glaucoma, there's retinal fellowships, there's ocular oncology, there's oculoplastics, there's refractive surgery based fellowships, there's uveitis fellowships. Like it's crazy just for this one little piece of the body that there's so many individual specialists within it. But I never really saw it as being like this really fragile piece of tissue that you have to just baby. I saw it as an opportunity to learn more about something that was just so intricate and beautiful, and make it more of like an art than if you come at it from that angle, it's a little easier to kind of take the whole perspective.
So that complexity didn't scare you per se. It drew me in a bit. It drew you in. Vision is such a deeply personal sense, right? Like eyes a window to the soul, the entire gamut of phrases that you could, or idioms that you can come up about what sight and vision and the eyes mean to the human experience. What does it feel like? What sense do you get whenever someone previously has some kind of diminished vision or no vision at all, and you're able to give that back to them? I asked that question because I equate shortness of breath as one of those things that people take for granted. Breath, in general. Sure. So when you're short of breath, not being short of breath is such a gem. Yeah. And when you're able to give that to someone, and we do it in a very simple way, we can give albuterol or inhalers, and someone swears you've changed their life. Yeah. Someone who's suffering with uncontrolled COPD, you give them an inhaler and they're no longer having that debilitating shortness of breath, either at rest or with exertion. And that does provide me a sense of fulfillment that I'm helping. In that old, when on your personal statement, when they ask you why do you want to be a doctor? Yeah. That everybody puts. Yeah. To help people. To save lives. Right. I get that. Yeah. From being a pulmonologist in that sense. What does giving sight back give to you in that sense?
Yeah, that's an absolutely amazing role that I've been given. That now I love what I do for that reason. Every Friday are my post-op days, and it's the best day of my week. Wow. I get to walk in the room and see, 20, 30 people see again. And to kind of build upon that, a quick story, went to Guatemala this past summer and did some mission work. And there was a lady that was completely deaf, completely blind from cataract, couldn't hear, couldn't see anything. And to give sight back to her, at least in one eye while I was there, changed that lady's life for the rest of her life. She could see her family. She could eat to cook. She could cook. She could eat. She could see to walk, to get around. You change someone's life in a 10-minute or less surgery. There's really few better feelings in the world, man.
I can imagine. It sounds deeply gratifying. You said 10 minutes or less. Is that average?
Yeah, for a lot of cataract surgeons that have been doing this for a while and have a lot of cases under their belt. Yeah.
And you've been practicing now for 10 years, the better part of 10 years.
So I've been out of med school for 10 years, a little over 10 years. I've been in my current practice for 6. So 6 years, 6.5 years now.
And this was your first gig out of
residency.
Straight into private practice.
Straight into private practice with an amazing guy, Dr. Richard Arsenault. Shout out to him. He's my partner in crime, my partner in the practice at Advanced Eye Institute in Thibodeau. And he's just he's only 5 years older than me. So whenever I came in, he was fantastic about just kind of easing my transition. So it was really good having him for that first year or two of really getting my feet under me, and is a big reason because of he's a big reason why I'm here still.
I love that. You hinted earlier that you viewed a lot of the intricate details in the eye as not so much daunting, but there's an art to it. Yeah. Do you feel ophthalmology? Because I think a lot of what makes a good physician is an application of art to the way they practice the science of medicine.
For sure.
Do you feel like ophthalmology also affords you? Is it a little bit more science, a little bit more art, or is it a healthy combination of both?
I think it's a great combination of both. So you get you scratch the itch in both places, right? So like the intricacies of how we do surgery with lasers to remove tissue, lasers to cut tissue, with these little tiny 6 millimeter implants we put in the eye to make people see again after their cataract surgery, and all the science that goes behind that is amazing. When it comes to the art side of it, though, that's really your being a physician, like you mentioned. That's where we can learn all of the science behind this stuff, but applying it to a patient sitting in front of you, that's where the art comes in. And describing all of the things, all of this new technology that's out there between the different types of lens implants and different types of surgeries we have nowadays, that's really where the art comes in, to really get to know the patient sitting in front of you, what they're looking for in terms of their vision, what's going to make them happy afterwards, and then applying the science to get to that point.
How much has that changed, the technology, from the time when you started to now?
Yeah. From most of what I do in terms of cataract surgery, there's been new lens implants that have come out every year.
Wow.
So
are they made by Apple?
Not quite there yet. These newer types of lenses that help reduce need for glasses, and they've been around for a while in terms of the idea and the technology, but they've just been refined over the course of that time, to where less side effects and overall better vision at more ranges of vision. And that's been almost every year something new's been coming out since I've been in practice. So keeping up with it can be a lot, right. But always having an open mind and always willing to try something, I think, is important in what we do.
I got LASIK a while back, roughly 6 years ago. I graded as a top 3, top 4 decision I ever made in my life. I was so mad when I finally was able to see that people saw this way.
Yeah.
I now wear glasses cosmetically, because my entire life I wore glasses. And it just so happens I got LASIK around the time of COVID. And I was so used to fixing my face. So in COVID, obviously kept on touching my face.
Yeah.
In a time when that was taboo.
That was tough.
Yeah. I've always wanted to ask an ophthalmologist, why don't ophthalmologists get LASIK? I feel like I haven't met many that. Yeah. I see a bunch of ophthalmologists that wear glasses, but they themselves don't get LASIK.
I think it's a very fair question. At least personally, from my standpoint, I'm slightly nearsighted. So, to drive, I need my glasses to be comfortable on the road. But for most other things,
you're good.
I'm pretty dang good. And I know what's going to be coming in the next probably 10 years is something we call presbyopia, which is losing your reading vision, which if I'm slightly nearsighted and I'm 45, I won't need reading glasses then. But you, my friend, you'll need reading glasses.
I'll need reading
because
glasses.
You have LASIK.
For real?
Yes. So, I mean...
And that can't be fixed by LASIK again?
There's some things that can be done. Something called monovision, which is you keep one eye for your distance eye, and we treat one eye for your reading. So there's some options out there at that point. But I just know that with anything we do, any procedure, there's risk, right?
Right.
If you have someone that's a -6, meaning they can't see a dang thing, but anything, if it's right here, they could see it. Besides that, they can't see anything.
Right.
For that person, yeah, it would be worth it, right? I'm just not in that boat.
So you're saying that the benefit of that improvement in vision has to be worth it.
100%. Just like anything else we do.
So just by virtue of having glasses isn't reason enough to get LASIK from your own.
Absolutely not.
Oh, I love that.
No.
I love that as a good pro tip.
Yeah.
Although I felt like my vision was pretty bad. I don't remember my prescription, but it was bad.
Like you had a hard time functioning without glasses on.
Oh yeah. When I played any sport and I took my glasses off, it took me about 10 minutes to get a feel of things. Like if I was playing basketball, it took me about a few minutes, a bunch of missed shots. I still miss shots, but a bunch of missed shots.
Yeah, we'll blame that.
Before I actually got a good like spatial like understanding. Yeah. But I didn't like playing with the glasses because then it's like you're seeing, it falls off. It becomes more limiting if you had the glasses on.
Yeah, and for like people's work, and I've done quite a few people that have been firefighters. You know, right. they can't wear glasses even if they're a minimal prescription. They can't really wear glasses with all of their equipment on. Mm-hmm. It really gets in the way of their right. So for people's jobs, there's certain thresholds for doing these things.
Are there, because when I was getting, I guess, worked up for it, there was LASIK, and then there was another one. I forgot what it's called. It's like a piece of thing that you put over the...
Yeah, so ICL.
Yeah,
intracolumnar lens.
Yeah.
So that's a lens that essentially... It's very similar in the way that we do cataract surgery. It's an incision on the eye as opposed to a laser on the surface. It's an incision on the surface that we then insert a lens with a different power that goes in front of your natural lens. And just if you're nearsighted, it takes away some of that power. Okay, essentially. And just focuses the light on your retina better. Usually reserved for people with a little higher prescriptions. That LASIK wouldn't necessarily be a good idea.
Is that different from, was it PRK or something like that?
So PRK and LASIK do pretty much the same thing.
Gotcha. What is something that is amazing about the human eye, or the eye in general, that still amazes you to this day? Something that always blows your mind, or something that you found really interesting and fascinating, either at the beginning or has persisted across all these years?
Yeah, just the entire visual system and how every single part of it has to be working for you to see. If your cornea has a scar on it, you don't see. If you have a cataract in your lens, you don't see. If your retina is not functioning well, you don't see. If your optic nerve is damaged from glaucoma, you don't see. Every single little piece there has to work in harmony to make the picture.
Right.
And that just in of itself is beautiful. And still just wows me and blows me away.
What have you learned from your patients that has changed the way you practice? What personal experience have you had with patients, especially, again, highlighting the importance of vision and the, I'm sure, catharsis that people feel and the jubilation that people feel with having that again? What kind of experience have you had that has changed the way you interact with your patients?
I think with anything that we do on a daily basis, like our jobs, you know, we can get in a mindset of you're just there again another day, right? And that can happen for even people like you that are taking care of super sick people in the ICU. You know, it can happen to anybody. We get in this mindset of it's another day, let's go to the grind and get it done, you know? But whenever you step back and you have those experiences of people that are, you know, you're changing their life by what you're doing, you're saving people's lives by what you're doing, you see it as another way to get up and go help someone else that needs you. The overall, like I guess most of my discussions with patients from a surgical standpoint comes from, it always ends up leading to talking about expectations and surgery expectations. And there's a lot that's out there that, the person I'm operating on, their neighbor just had cataract surgery last week and they have perfect vision without glasses, right? Mm-hmm. And that's not the case for everybody. And just hearing, having those conversations with my patients and hearing, hey, I thought this was going to happen. Like having that conversation on the front end and really diving into that about the different options and different expectations after these surgeries. That's evolved a lot over time.
To dive into those meetings and those clinic visits where you're introducing the idea of having surgery, how do you establish and build trust for someone who is terrified of the concept and idea of potentially? Because I'm sure, because we say it for even the most mundane of procedures, there's the risk of these really bad things happening. Right. And I'm sure you almost certainly have to say, there's a risk for, vision loss, but I've done 1,000 of these and I haven't had a single one kind of thing. But how do you establish that trust for someone who obviously isn't informed and is otherwise ignorant of, your expertise at large and how safe a procedure is generally? How do you establish and build on that trust?
Yeah, I think it just comes down to talking to people, man. And from like the initial interaction to shaking someone's hand and looking in them in the eye and introducing yourself and talking to the patient's family, like not forgetting that someone else is in the room. That's where you start building your trust from the initial just walking into the room. Most of my patients tell me that I still look like I should be in high school. So that's another barrier that I've had to overcome over the last 6 years. That's the little 5 o'clock shadow beard was part of that. But just having confidence in what you do and describing it to people on a level that we can all understand. They don't get that a lot of other places and don't get that from a lot of other doctors, unfortunately. So just sitting down and explaining things on a human level, that's how I practice and that's how I build trust with my patients.
You have a tremendous reputation. I hope you do know that, right? Like you have a quite fantastic reputation.
Thank you.
Down the bayou. Yeah. And then when we did our research for this episode, because we do, nothing but positive things. It was absolutely, it was truly overwhelming in a way. I was like, him?
That guy?
That guy?
Yeah. Well, thanks, man.
The world's changing a lot. The world's changing very, very quickly with technology, obviously medicine and healthcare, AI, robotics. You mentioned 10 years down the line, I may need glasses to read. How is ophthalmology? What do you see ophthalmology evolving into over the next several years with the context of how quickly technology and advanced and artificial intelligence is now becoming kind of integrated into every component of our daily lives?
Yeah. So I guess from a AI standpoint, within the next 10 years, just knowing the number of patients that I need to see every day and knowing that there's not many ophthalmologists, at least in our area, it's going to start getting more and more overwhelming. And I think AI has a role to play in that. And for us, in terms of like initial screening, which it's already being done. Most of what we do as ophthalmologists, which is one of the things I love, is 90% of patients that come into my office, the answer is in front of me. I just have to look, so it's sight recognition. There's something there that's wrong and it needs to be treated. It's not like I need to order an MRI on every patient that I see, or a CT scan, or I just look and I know what's going on 90% of the time. Okay. That's what AI can do, right? So I can take a picture,
send it to AI,
and pattern recognition can pick up on, okay, that's a big optic nerve. You put in the patient's eye pressure. Okay, this patient is at high risk for glaucoma. They need to go see somebody. So I see that as being a beneficial thing potentially, as long as it's not taken away from the actual clinical expertise of the physician. And we're not just training a bunch of dumb doctors that put stuff into a computer and it spits out a diagnosis and what you need to do. I think we're still protected a little bit from that in ophthalmology, just because it's pretty heavily procedural and surgery based. But I think on the front end, it would be helpful if we could like scan and treat those patients earlier from like glaucoma, triage patients earlier from like a glaucoma or diabetic standpoint, or even macular degeneration standpoint.
What's a misconception? Actually, better yet, when you tell folks that you are an eye doctor, or when that comes up, what do people think you do that you don't actually do?
Oh yeah, the like number one thing that I hear all the time is I take the eyeball out of the head, do the surgery, and then I put the eyeball back in the head, and that's
the number one thing?
I hear that on the daily.
There's no way.
I'm pretty sure it was some little guy in Cutoff, Louisiana that spread it this rumor or something, but I don't know.
There's no way.
Yes, there's a lot of people that think that. We don't do that.
At all.
At all. You can't take the eyeball out.
Oh, wow.
Yeah.
That is hilarious. I thought you were going to say something else or anything else. But
no, people, I get that question quite often. Are you taking my eyeball out and then putting it back? Like, that's how we do surgery. You
should have this clip at the beginning of all of your visits.
That'd be great.
And just let them know, look, we are absolutely not taking your eyeball out.
It's staying right there.
Now that we've gotten over that.
And I guess a big part of it is like, just conceptually, they're like, my eye's here. How's he going to get there to actually do this surgery? So I guess that's where it came from. But
how do you do that? How do you get there?
Yeah, so most of my surgeries, it's the patient's lying flat and their face is flat. And we're prepping the eye like we would prep any other surgery with betadine. We have a drape on the eye and then a little eyelid speculum that keeps the eyelids open for us. And we operate under a microscope. A lot of people don't realize this, but we use both hands to operate and both feet. Our feet aren't anywhere near the eye when we're operating, but they're controlling our pedals that control the microscope and what's called our phacoemulsification machine.
The feet are doing that.
The feet
while your hand is doing the actual and I'm
manipulation.
And I'm sure the movements have to be very fine, obviously, because of the space.
Yeah, so it's about 3 millimeters in the front of the eye that we're working, and then I guess for mostly cataract surgery we're talking about, like there's about a 3 micron piece of tissue, but between you having a good day and you having a longer day, that can be complicated and complex if you hurt that piece of tissue.
For context, I think the human hair is about 5 microns.
Yes. Yeah.
That's actually insane.
It's pretty awesome.
Clearly.
Yeah.
Why you became an ophthalmologist and I did not. Wow. That is actually bizarre to me. What in that vein, then, what is a misconception about the eye that is wrong? A misconception about the eye as an organ that people have, or you've heard, or is espoused in public, as part of public knowledge, wives' tales, if you will, about the eye that is not accurate.
I would say maybe one of the more common things, besides not removing the eye for surgery, is reading glasses. I mentioned reading glasses. Yeah. Most people need reading glasses, 40s to 50s starting, and there's a lot of people that think it hurts your eyes if you use them. Because the natural progression is that you need more and more power over time as we age to see more and more up close. So a lot of people start off with a low power, like a +1 pair of reading glasses. And then in a few years, they need a 150 and then a 2 and a 250. And then they're like, wait, these things are making my vision worse. And it's not actually that. It's just the aging process. Yeah.
I just made a connection between the minus and the pluses. Is that plus still is that still on the same scale as the minus that you mentioned earlier? Like someone having really bad vision having a -6?
Yeah. So like what your prescription of the eye is, -6 is that you're very, very nearsighted. A +6 is you're very, very farsighted. And
0 is there a 0?
Plano, meaning no prescription.
So me now.
That's what you want.
With my LASIK.
Yeah.
I probably have 00.
Yeah, it's very good. Yeah.
What does the future look like for ophthalmology?
Yeah, so one of the big things, I guess, within the last 5 to 10 years, and it's going to continue, I think. And I do a lot of this. It's something called minimally invasive glaucoma surgery, MIGS surgery.
Which is surprising to me, as if any type of glaucoma surgery isn't by default minimally invasive.
Right.
That's hilarious.
There's some pretty
1 micron
large, like pretty higher risk glaucoma surgeries, traditional glaucoma surgeries that were kind of withheld until late stage glaucoma. And a lot of people, just because of the risk of the surgery. But within the last 10 years, these MIG surgeries have come out, and most of them we do at the same time of cataract surgery as well. So pretty much anybody with glaucoma that we're doing cataract surgery on, we're also doing a MIG surgery. And we found that we're doing so much less of the major glaucoma surgeries now.
Because you're catching it earlier.
Because we're treating earlier, essentially. Which has been a huge shift in how we treat glaucoma in the last 5 or 10 years. And there's always new devices from that front coming out. There's newer things we're hoping on macular degeneration that will come out. There's stem cell research, gene therapy research going on from a macular degeneration standpoint. And that's the tough disease that we have from a retina standpoint. I'm not a retina specialist, but we only have treatments at this point for end-stage macular degeneration. Whenever it's bad, if there's treatments for very early mild stage macular degeneration, then that can save so much vision in the future. That's really what I would look forward to.
If someone is looking to see an eye doctor for X reason, what is a marker for them? What is something that they should be looking out for that means that they should go tomorrow? Like, go see one today.
Yeah. So luckily, there's very few eye emergencies, which is another perk of my job. So like, I guess the bigger things, if you get chemicals in the eye, like bleach, that's bad. That can end up really bad. Go to the emergency room, and then go to your eye doctor after. Really painful eye, that's red, that's blurred, and the pupil's not moving. That's usually like angle closure glaucoma, and that has to be taken care of right away. People lose vision from that if it's not treated immediately. Retinal detachments, early stage retinal detachments are emergencies and usually have to be taken pretty quick. Which flashing lights, like usually like lightning streaks in the vision, are floaters. These little black dots, kind of like a snow globe. If like you feel like a snow globe went off in your eye,
and it happens instantly.
Happens instantly. If you get any of that, or like a curtain or a shade coming across or up or down in your vision,
amaurosis fugax.
Those are things you need to be worried about. Amaurosis is also emergency because it's a telltale sign of a stroke. So amaurosis is blacking out or graying out of your vision for up to 3 minutes or so. It's usually not a long time, and then it comes back, and then your vision comes back. If you have that happening quite a bit, like a couple times a day, it usually means that there's either carotid blockage and carotid plaque that's breaking off, or you have some sort of clot somewhere that's breaking off.
Are there screening protocols in ophthalmology? And I'm asking that because, for instance, in lungs, we do a lot of low-dose CT scans for lung cancer screening for patients that smoke for an extended period of time.
Yeah.
An extended amount of, cigarettes, pack years, essentially.
Yeah.
Vision loss is inevitable, right? Because of aging.
If we all lived to be 150, we'd all be blind.
We'd all be blind
from glaucoma or macular degeneration. I'm pretty sure.
So it's what really is pathologic is obviously the ones that are acute. The macular degenerations and things like that, retinal detachment. But vision loss itself, what makes it problematic is if it comes prematurely.
Right.
Are there screenings that people can do in general to see where they're at? Like, at what age should we be doing yearly eye checks, if that's even an option? Yeah. If your eye is fine, should you be getting yearly eye screenings? Yeah,
so I think it's the American Academy of Ophthalmology recommends, I believe the age is 50 and older, 55 and older, getting a yearly eye exam. My average patient is probably like 60 or probably closer to 70 years old.
Really?
Yeah. Most eye diseases come later in life.
Right.
So that's why if you start at 50, 55, you'd be catching most of the things that would creep up on you with age, in particular glaucoma. I've seen way too many people go blind from glaucoma, something that in majority of people we can prevent if it's caught early. I know that there are like community health screenings that include eye exams, but really what you need is a good dilated eye exam to catch glaucoma. Even an eye pressure check isn't sufficient. Eye pressure is a risk factor for glaucoma. It doesn't mean that you have it. So a high pressure puts you at higher risk of it, but people with glaucoma can also have a low pressure. And there's a subset of glaucoma called low tension or low pressure glaucoma that can steal vision even faster than regular glaucoma.
Oh, wow.
So it's really just getting your routine eye exam starting at age 50.
The way I've described glaucoma to myself is some kind of hardening or calcification of the lens. Is that an oversimplification?
That's cataract.
That's cataract.
Yes.
Tell me what glaucoma is.
So glaucoma is...
I'm glad I said
yes, that. I'm glad. So glaucoma really is an optic neuropathy. So it's an optic nerve disease. So it's slowly damaged optic nerve that happens over time for multiple reasons. We don't know 100% why people get glaucoma, but we know that there are several risk factors for getting it. So once you lose an optic nerve tissue is CNS tissue. It's coming straight from the brainstem. Once you lose it, it's gone forever.
Right.
So it's more of a preventative treatment. So once we diagnose you with optic nerve disease that's causing a pretty characteristic peripheral vision damage, then you have glaucoma, and we can, hopefully the idea is we prevent it from getting any worse at that stage.
And that's where these surgeries and minimally MIGS, minimally invasive glaucoma surgeries come into place.
Yeah.
Wow. Okay. I didn't realize that it was, and that's the majority of things that you're seeing. If your average 100%. Patient is 60, 70, I'm sure that's your bread and butter, essentially.
100%. Yeah.
Wow. What have you been doing as a hobby these days?
Yeah. Man, I have a lot of hobbies, I guess. But more recently, I guess the biggest one is I'm trying to get you to come with me. Got my private pilot license last year, right at a year ago, and working toward what's called an instrument rating right now, and just really enjoying it. It's a lot of work, and it's I say it's a hobby, but it's really like a very strenuous hobby.
Right,
like you have to go fly.
Right.
Like it's not like I enjoy soccer and I go play soccer once every month.
Right.
You know, this is something you have to be out there learning, practicing. It's a continuation thing. But I've always loved the idea of aviation and the science behind it. I've loved physics in high school, throughout college. And that's initially, I think, what kind of sprung my interest in it. And now that I'm in the plane and getting to fly every week, it's you leave everything else behind because you can't take anything else with you, right?
Yeah.
You have to be 100% focused on what you're doing. So everything else from work, from your life, from family, you leave it behind and you go up in the air by yourself and don't do anything else besides fly a plane.
It's
a great hobby.
I think you and I have definitely had this conversation.
Yeah.
The very first dream I had was to be a pilot, and it still is.
Yeah.
And I don't know if I told you, but I did my discovery flight. Did I tell you this?
You sent me the picture, man. You looked happy.
Oh my goodness. I love it.
Yeah.
I've always wanted to be a pilot, and the plan is to go ahead and get me at least a pilot's private license as soon as possible.
Yeah.
Of course, I have to convince my wife to, be
that's
tolerant
step one.
of that. That's the
you
most
start
important.
there. Start there. Yep.
So that's the most important step.
Yeah.
But man, I did that. I actually did the discovery flight in covert. Like I had to secretly do that. Right. So I was just like, oh yeah, I'm going to, I don't know, rallies.
And you went flying.
And I went flying a plane.
That's awesome.
So you have your private pilot's license. So you can fly. You can fly a plane.
I can fly a plane on my own. I can bring whoever I want, and I can't charge them. So that's I guess that's one of the caveats to just a private pilot's license. If you go on and get a commercial license, then that's when you can actually start flying commercially for different companies or by yourself and ferry a flight and charge people to to actually pilot them.
Right.
Right now I'm working on my instrument rating, which I think is just one of those things that every pilot really should have. If you're planning on going beyond your home airport and actually traveling somewhere, I think an instrument rating is necessary.
My understanding of instrument rating is basically flying based off of just the instruments, just of the tools that are available to you on the airplane.
Correct.
And it's not vision flying.
Correct. 100%. And I mean, where it comes into play is flying in clouds.
Mm-hmm.
If you get into a cloud layer and you can't see anything, you need to know that you can trust your instruments and how to use them properly to get through that. And honestly, I found that it's actually an easier rating to get. The private pilot's license was, the learning curve is so steep initially. Now you know how to fly the plane. You're just basically following directions, and it's great. But I think it's so important to have that extra layer of protection for yourself and for really whoever you're flying, if it's your family.
Was there any part of the process that reminded you of what your regular of being an ophthalmologist, the technicality of being an ophthalmologist?
I mean, I guess the stringency of it. So like, we go through medical school, we go through all of these things, we take tests and have practical tests, and the FAA is pretty dang stringent when it comes to like testing, and passing tests, and you have a practical in order to get your license. And that was probably harder than some of my ophthalmology boards probably. I don't remember those too much, but no, it's pretty stringent, and you have to put in a lot of time to get through it.
What was the most difficult part thus far?
Honestly, my practical test was just very stressful for whatever reason.
Because it was a test, or because it was uniquely difficult?
I think it was partially a test, partially that it was a test.
Hold on, sorry.
No, you good. Yeah, I think it partially was just, it was a test. I knew how to fly the plane, but I didn't necessarily know what he was looking for. That part was probably the hardest step to getting my private license. But in terms of like flying, landings. So the maneuvers are pretty easy to catch on to, but landing, there's a pretty steep learning curve.
I've heard
that's the only way you got to get down. So you got to learn it one way or another. But it is probably the hardest part.
Yeah, that's what I've heard pilots say, that landing is by far the most challenging and even mentally taxing component of being a pilot. Yeah.
And I think part of it too, it goes back to expectations, and like when people are flying with you, they expect a really nice, clean, crisp landing, and the pressure's on to deliver that every single time. Because I mean, you can land the plane and it'd just be a really hard landing and everybody's safe. But they're like, God, that guy, he's not very good at this, People
will judge you for it.
Oh, people will judge you for it, 100%. Yeah.
Have you been able to fly someone other than your instructor? Like, has Jade been on the plane yet?
We were planning a flight, but once again, I don't have my instrument rating right now. So, and the weather was slightly questionable in terms of cloud layers and stuff. So, decided not to. But no, she hadn't been in the plane with me yet.
How much longer till you get the instrument rating?
I probably have another 10 to 15 hours.
In terms of hours, it's 40, right, for pilots?
40 hours is the required minimum. I think most people probably go a little bit more than that before they feel comfortable. Yeah.
How many have you now accomplished in the last 2 years, essentially? How many?
Yeah, I mean, I fly once a week at the most, maybe once every other week, just depending. And I think I have close to 80 hours at this point,
Nice.
90 hours. So
If I was to do it, because I do have that week off, I would stack so many weeks.
100. That's the way to do it.
Yeah,
So if you can fly back to back, you'd pick it up much faster.
Right.
Like the way that I had to do it with my schedule and family and work and everything. At the most, I could fly once a week. So at the very beginning, with there being so much information to kind of hang on to for that entire week, you'd lose it. And then it would take a couple landings before all right, I got it. I got it again.
Right.
And then you learn a bit more from there. So if you can stack it, that would be great.
How confident are you now when you get into a plane? How confident are you? Like, is it like driving a car? You're just like, oh yeah.
Still not like that. It's still it's still going through every checklist, and I made it a point early to try not to get like to that point where I just hop in the car and go type thing.
Right.
Just from a safety standpoint, I think it's a good idea to still go through every single checklist mentally and physically. And, but in terms of taking off, getting where I want to go and landing, pretty confident that I can do that pretty much every time.
And you're flying by yourself now, right?
Yeah, I can. Yeah. For the instrument rating, I'm still flying with an instructor, but yeah.
Wow.
Yeah, man.
Doctor, pilot, Jonathan Carrere. Thank you so much.
Thanks, buddy. Had fun.
Thank you so much for joining us today. If this conversation resonated with you, there's a lot more where that came from. We've got stories from healthcare providers, healers, innovators of various industries, and people doing work that truly matters, each one bringing something very different to the table. Feel free to check out another episode and subscribe so you don't miss what's next. And if you know someone who would enjoy or needs to hear this, share it with them as well. I'm Ugo Ezema, and this is The Last Zebra. I'll see you on the next one.